I just want to welcome everyone to the second installation of the ASSFN webinar series on transition to practice, with the theme today being negotiating your position and advancing to leadership as a functional neurosurgeon. For those of you who don't know me, my name is Nehaw Sarmey. I'm a junior faculty at University of Arizona. I'll be helping to moderate today's session. And I thank the ASSFN team for this opportunity. Moving on to our two speakers for today's session, we are delighted and honored to have two very special guests with us this evening, Dr. Jason Schwalb and Dr. Joseph Neimat. Both are highly accomplished surgeon leaders, educators, and innovators in the field of functional neurosurgery. So we're very excited to hear from them from their experiences on building one's career in neurosurgery and advancing up the career ladder and taking on new leadership roles, so to speak. So I think we've got a range of people here in the audience, really, from trainees to early and mid-career staff, as well as some more seasoned neurosurgeons. So I think there will be some great information, great insight through the session today that's going to be applicable to all folks across the group. So we do want to make this an interactive and engaging session, but just out of respect for both of our speakers, please go ahead and enter in your questions into our chat that we'll be able to see, myself as well as the speakers. And then towards the end of the session, we should have about 10-15 minutes to address as many questions as we can take. So as questions come up throughout the talks, just add them to the chat and we will address them towards the end. So I want to introduce our first speaker, Dr. Jason Schwalb. He is the Director of Functional Neurosurgery at Indiana University. He holds the Betsey Barton Endowed Chair and Professorship. Just prior to this, he was at the Henry Ford Health System for many years, where he also held multiple clinical and academic leadership roles, including serving as president of the Michigan Association of Neurological Surgeons. He has also been president of the Joint Section for Pain and on the board of directors for the ASSFN. His neurosurgery training was at the University of Pennsylvania with an enfolded fellowship in spine, followed by additional fellowship training at the University of Toronto in functional neurosurgery and also in complex peripheral nerve. He's also been heavily involved at the state and the national level in work related to healthcare equity, quality improvement, and resident education. So let's all please welcome Dr. Schwalb.
Thank you, Nehaw.
A presentation on, just kind of your perspective on how you built up your career. If you don't have formal slides per se, but just kind of talking about how you started on your career and the steps you took, kind of moving up further up in leadership positions, as well as with your recent transition from Michigan over to Indiana, what that looked like, and any advice you have for folks that are negotiating first positions versus positions later on in their career.
Yeah, I mean, I think coming out of training, you want to find someplace that's a good fit, and you might want to find someplace that you're going to stay forever. But the reality is, a lot of people are not going to stay someplace forever. A lot of it is based on the timing and what's available. I feel pretty badly for people who were coming out of their training, be it fellowship or residency, as COVID was hitting. That was a very tough time. Unfortunately, I didn't have to go through that. I think in general, when you're looking at a job and you see what the options are out there, which may be limited, you want to find a job where the incentives and the goals of what the person who's hiring you is looking to do are kind of a good fit, where you want to do similar things, whether that's basic science research or having a big broad practice or having part of a practice. And these are all things you're going to want to negotiate. I think for functional neurosurgery, I see some people, they come out of their training and they want to just do DBS or just do epilepsy. And then there are people who want a broader practice where they want the full spectrum of functional neurosurgery. And that's sort of what I wanted. And so I think really trying to figure out what your boss and your leadership is looking for, and whether that's going to work and whether you're going to fit there is of utmost importance. And the incentives have to be aligned. So I can tell you, like, my first job out of training was an academic medical center, but it was basically a private practice where you paid a dean's tax and a tax to the department. And I got statements every month, showing me what my collections were. It wasn't even RVUs, it was collections. And then I paid our billing office and my secretary, out of that. And for functional neurosurgery, that's never going to work. You're never going to make a good living just based on your professional fees. And so, you want to have things aligned. And so in my first job, where I was for 3.5 years, yes, I had a robust DBS practice, and a robust peripheral nerve practice too. But basically I had, 70% of my practice was spine surgery to support my DBS hobby. And as I grew the DBS practice, my professional fees were actually going down, not up. So I think for functional neurosurgery, I think in general, you're probably going to be better off in a situation where there's some sort of consideration of not just your collections or even your RVUs, because the valuation of RVUs is pretty low for functional, but you really want to have some way of having investment in your program, because the reality is that the hospitals actually do very, very well on the hospital side of things. So for those of you who are in training or just coming out of training, there's the professional fee that you get paid that's rated on RVUs and tends to go down every year, especially when compared to inflation. And then there are the hospital fees and the facility fees. And so, as a result, like, as professional fees have gone down nationwide and hospital fees continue to keep up with inflation, the hospitals have had more and more power. And so, whereas 20 years ago, something like 70% of physicians were private practice, now it's only about 20%. And the only people who can remain in practice are people who have some sort of way of getting income that's not just professional fees, be that from owning an MRI or physical therapy. Or if you look at some of our pain colleagues, they have physical therapists and a pharmacy or other ways of capturing income. So that can work, if you want to do pain and have a practice like that. And, there are people out there who are very successful at that and do a lot of industry sponsored trials, which can really help financially, because they tend to be pretty lucrative. But you have to be into that business side of things. And I think it tends to work better if you're doing more outpatient procedures, especially if you own a piece of your ASC. So that's one model. I think most of us, and I think most of the leadership in ASSFN tend to be more hospital employed, either in academic settings or in group practices. And there you have to kind of leverage and negotiate on the basis of the whole package, what you bring in. And that's not just professional fees. In fact, your professional fees tend to be a small part of it. If you're doing epilepsy surgery, you're bringing in a fair amount of money to the hospital for EMU admissions for phase 2. You're helping with US News and World Report ratings for neurology and neurosurgery, because a big part of that is NAAC status. You are bringing in a huge amount of money for imaging. And that's actually, and then there's the fees, for the hospital for what you bring in when a patient comes in under craniotomy DRG and tends to do well and go home. And that's true with DBS as well. Our patients tend to do well and go home quickly, and yet the hospital collects a craniotomy DRG. So when you're negotiating your salary or when you're trying to figure out your value, you have to kind of look at it in the whole package. And in general, in negotiations, you know, you need to know your value, and your value is not your professional fees. You know, your value is what you bring to the institution, be it in research dollars, be it in hospital fees, be it in downstream revenue. And so if you're going to negotiate, you need to know that. I think in general, the other thing you need to do as you're negotiating is try and make things win-win, so that you know, you really kind of come over to the other side of the table in your negotiation and incentivize things that are important to you, but are also important to the institution, be that in volume growth or academic productivity, or anything else. So that's sort of the way I would look at negotiations. In terms of you know, later in your career, you know, my negotiations coming into this new job were very different than my negotiations going into my job at Henry Ford, because I had more of a reputation. I sort of knew what I brought to the table. I tended to know my own value, and you know, they kind of searched me out because they wanted some of the things that I had been successful in the past, and also, you know, my ability as an older guy now to, you know, mentorship, to mentor junior faculty, to mentor fellows and residents. And so that becomes an important part of the package as well, as what you're going to do there. And so I think it's important to, you know, to be able to do that, focus on the things that are important. Strategy in general is not just about choosing what to do, but also what not to do. And trying to figure that out as to how you add value and how you can mentor other people to pick up parts that maybe you don't have. You know, if you're not I'm not a basic scientist anymore, I don't run a lab. So, you know, for me, it was very important to be able to figure out how do we support someone who's going to do that and complement me well. So that's sort of my brief spiel. And I want to leave a lot of room for Joseph to speak, and also for questions.
That's great. Yeah, thank you very much.
Oh, there's one other thing I want to say. You know, I think Andres Lozano, who was our, you know, Joe and my fellowship director, you know, he always said, when you're starting out, you know, don't go to someplace where you're the smartest person there. You know, you need to have mentorship. It might not be in neurosurgery, you know, it might be in neurology or in neuroscience or some other field, but you do need to have some sort of mentorship, because otherwise you tend to stagnate.
I thought he only told me that. I thought that was
Yeah.
because I, in particular, needed someone clearly not the smartest person needed to know.
I think that's great points. And I'm sure there's going to be some questions, or I have questions too about mentorship that we can touch on later this session. Thank you very much for sharing that, Dr. Schwalb. So, Dr. Neimat, did you have slides?
I do, yeah. I have a couple slides.
Okay, so before that, I just want to kind of more formally introduce you. So our second speaker is Dr. Joseph Neimat. He's a professor and the chair of the Department of Neurosurgery at University of Louisville. He completed his neurosurgery training at Massachusetts General, followed by fellowship in functional neurosurgery, also at University of Toronto. So common thread here. He was previous to Louisville, he was at Vanderbilt as a director of epilepsy surgery and psychiatric neuromodulation surgery, also director of human neurophysiological research. He's been a leader of multiple NIH-funded bioengineering research collaborations. And in parallel with various clinical and academic roles that he served in, he's been involved with education for residents and medical students, and of course also organized neurosurgery, and served as the most recent ASSFN president. So Dr. Neimat, please go ahead.
Thank you, Nehaw. Thank you for the very kind introduction. I'll start by saying Jason and I were fellows in Toronto at exactly the same time. We were co-fellows, and if you had told me then that we would be leading a conversation about how to lead a career in functional neurosurgery, I would never have imagined this. So it's fun, in particular, to be doing this with Jason and with all of you. I would love to make this interactive. I don't know if there are ways, like if people want to put questions up while I'm doing this. I have a few slides. They're a bit philosophical, kind of big picture. And I guess I should share those. That would make it easier for you guys to see otherwise. Let's see. Can people see my screen there?
Yes.
Okay, great. And I'll open the chat so I can see that too. Okay. So I'll give just some big picture philosophical things. I'm going to talk a bit about what maybe jobs in general in functional neurosurgery, and then sort of the opportunity that I was presented with at some point is to be a chair. I think there are more chairs, some on this call. I saw Julie's here and maybe others. More functional surgeons becoming chair people of departments, and I think that's nice to see. I think there are some reasons for that. I think that a lot of the things that we do in functional neurosurgery lend themselves to the kind of leadership that is required in departments, and I can maybe speak to that at the end. Just progressing. So here, these are my disclosures. None of these are really related to this at all. I guess the appropriate disclosures were, I have a job. I'm paid to be a chair. Some of what I'm going to show you might be off-label chairpersonship, I guess maybe. So I'll kind of go through it in that way. Just a note on, as I was writing this, it feels very clumsy sometimes to use the terms that we have. Chairman, I don't think is appropriate anymore. Many of the new chairs that we have, chair people, are female, and that's wonderful and important. It's a little strange to designate people chairmen or chairwomen. Chair often gets confused with endowed chairs and committee chairs. I think we need a new term, and so I welcome anybody who wants to suggest a better term for the head of a department. I think it would be nice to have that, but for the purpose today, I'm going to try to use a chairperson. If I slip and say chairman, it's not intentional at all. I think this is importantly a job that everyone is doing. So I'm going to start with a few slides that I've used for years when I talk to people about going out and getting a position, independent of chairmanship, but chairpersonship. But what I tell people is, as you go out and look at that first job, have a compelling direction. You've done a lot of things, everyone in this group, and this echoes what Jason said. It's important to know your value, and what you're presenting to a potential employer is, all the things that you're doing and your enthusiasm for going and doing that in their department, in their center. And so I think that is really important. My residents are sick of seeing Wile E. Coyote, but I just love this image, this idea of just moving forward and sort of damn the torpedoes. I think that's exciting and important. People talk a lot about fit when you look for a job. I think fit is kind of a rare finding. You occasionally find a position where someone has left and it's pretty much what you want to do. But I think even more important is the idea of alignment. The idea that a program is growing or wants to grow, that it has a strong interest in the sorts of things that you are also doing, and that your interests and their interests are aligned. I think if you can find that at every level, whether it's your first job or moving to be a chair or something in between, I think it's nice to find that kind of alignment. This always should be a family decision. It's important, when residents and fellows come to me, I say, first and foremost, make sure that you involve everybody. This isn't a one-person decision. This is your entire family. And so that, I think, is critically important. And then I think almost as important is mentorship. Look for mentors who can help you. This is, what Andres told us as we left our residency, but it continues to be important. Even in a second job and third job, and even coming into a position as chair, it was important to know that there were colleagues that I had, other chairs. I have in my department, Hank Nauta, who is a senior, has been a chair of a department and retired, and then came to be our program director. And it's wonderful to have just someone to bounce ideas off of. It's something I'm very grateful for. So that you never, I think, get past the need for that kind of guidance. And this I think is important. You want to go to a place where people value what you are bringing and value your opinion. So, looking for places where they really are going to trust you to lead and grow whatever endeavor you're working on, your program, et cetera. I think is really important. And reciprocally, as chair, I really think a lot about empowering the people um, that I've hired that are part of the department, because in the end, the best departments I think are built of people who are themselves leading independently and are doing things. I know a bit about functional neurosurgery, but I don't know a lot about spine surgery or the cutting edge of vascular surgery or many other things. And so having individuals who are most excited about that and wanting to lead it, I think is really gratifying and builds the best combined efforts, the best departments. And so when I give that talk on just jobs in general, I often end with this, right? Okay, so you've had that first job, it's going well. When do you decide to make a move? And that is a really difficult decision because there are no perfect jobs. Every job is going to have its ups and downs, and you will invariably. I tell people when I hire them, I say, hey, listen, a couple years from now, if you take this job, you're going to be frustrated, and you're going to be, this damn Neimat, he does this and he does that. It's important, to be alert to that and to look around and make sure that you know what you're getting into, because there are always going to be days when you're not happy or you're frustrated. Most jobs improve through force of effort. So invariably the job that you take on when you start is going to be different as you are there, being a force, for good. The things that you are interested in, you will grow and build. The people that you influence will become part of your team, and that becomes a huge asset in any job that you have. So jobs will improve over time. It's important to be alert to that, but also to know when you've hit a ceiling. So you should identify and be open to opportunities. They will come along, at every level of your career. And I think, and this is sort of transitioning to the idea of moving to be a chairperson, the best moves are transitions in career scope. So, when you are taking on a fundamentally different job, that I think becomes an exciting opportunity to really think seriously about, okay, is this the time to make a move? So what is that, right? So, we all have, this is sort of your standard learning curve. And many of you I saw on the call are a lot of, at every level. Looks like we have some young attendings, we have some more senior attendings, so we have some chairs, but we're all going through this in our positions, right? There's a period where we're learning. You get to this very steep part of the learning curve. That is exciting. You're getting better all the time. And then at some point you wonder whether you've sort of hit a plateau, and it's difficult to know. And ideally what you would like to do is to make a transition, that there's some point where you say, hey, now it's time to leave and I'm going to start that new job. This is a much more common thing, I think, in other, in business, in other industries. This idea is somewhat routine. Almost strategically, people move every, whatever it is, different for different industries, 3 to 5 years, and they make that jump, and now they're in another place. This is a slide that I borrowed. I would not recommend that you do this every 3 to 5 years in medicine. That, I think, for neurosurgery would be, it's just difficult to build anything in that period of time. But there is some timeline where that might be meaningful. And I think making that change, whether you stay in your own job or whether you move to another job, taking on new learning curves, I think it is an important part. There have been several studies that talk about this as a way to prevent burnout. I think to the extent that you can stay on that exciting part of the learning curve, that is an important element in your career satisfaction and in preventing burnout. This transition is difficult, because you don't see the next curve ahead of you. You sort of see the one that you're on, and you can kind of feel some of this. There's a period of growth, you hit a period of maturity, and then there invariably is this period of, I don't know what to do. There's a choice, there's a potential for change, it feels chaotic. And it's hard to know, is this the right point? Have I hit that plateau? Is it time to make a new beginning? And, we always have this fear that if we don't do it, this is a little bit of a bleak slide, but yet, drift, denial, and death, maybe not that bad, but you may come to a point where you've exceeded your opportunities there, and it's time to really look. So, so to become a chairperson, what is that like? I guess, imagined before I did it that it would be something like this. It would be glorious. There would be shining lights. There might be, singing and who knows what. It is really rarely like this. It's a little bit more like this. There is a lot of work to be done. There's a lot to clean up, depending on the kind of move you make. And fundamentally, you are the person to do it. It doesn't matter what the crisis is. I say that I take trauma call some number of nights a week like my other faculty, but I'm always on drama call. No matter what goes wrong in the department, that call comes to me. And so, it's important to recognize that just like being on call, it's a responsibility, but it's an opportunity. It's nice to be entrusted with that, if you feel that you can make a difference and shape the department with those responsibilities. I think something that is somewhat unique to academic medical centers is that, unlike other businesses where people have sort of serial managerial appointments, academic medicine is unique in that you rise to the position where you might seek a chair, because you've been successful in research, you've been a talented clinician, you've done all these other things, very few of which actually are management, are the things that are kind of your day-to-day work running a department. And so we all go through, making a leap from the things that we're doing every day that we're very good at, being a physician, seeing patients, doing surgery, doing research, teaching, whatever that is, to suddenly, gee, you are the head of a 200-person department, and that's essentially a moderately sized business that is doing a business of maybe $40 million a year. That is a unique shift that you go through making this change, and that's important. And it's important to recognize that. Invariably, this is the Dunning-Kruger effect. We often use this when we talk about innovation. This is really this curve, which will be familiar to some of you. What was established in terms of somebody's progression toward expertise. And the sense is, you sort of start out, you really, as a beginner, you don't know anything. There is a period where you are thinking quite quickly and you believe that you know everything. And particularly, if you're looking at your current department chair, you say to yourself, well, I can't believe all the things they're doing. I wouldn't do it that differently at all. And right around that point, when you're at the peak of this, I think because you're sort of seeing a little keyhole of what that person might be dealing with, you say, okay, I'm ready to be a chair myself. I know how to do it much, much better. And what you find very quickly is that it's just not that easy. There's a lot to consider. And so I liked this diagram because it sort of has all these curves. You probably know some, a little bit, but there's that is going to increase gradually. One thing, as you begin to get expertise, you begin to realize how much more there is to know. And doing the job I do now, having done this for 8 years, I think I know quite a bit more than when I started, but I realized that there are many, many other things that I could know. And that's part of the reason that I rely on a really expert team of both administrators and other physicians and other individuals that really help run and grow the department. How is it, just is this making sense to people? I always hate giving these Zoom lectures because I can't tell whether this is this resonating with people. Are there any questions or anything I can answer for people? Otherwise I'll keep going. Is this the direction people wanted, or is this just too?
I think this is great. Yeah, I mean, I see some thumbs up in the audience, and there's questions pouring in through the chat as well that I think will be great.
Okay. Oh, I can't see those. So feel free if I'm not seeing the chat. So if there are any questions, please feel free just to interrupt me. I'd be happy to answer questions as we go. Getting a little bit into the nuts and bolts and sort of reflecting on what it was to sort of take on this position. I've spent some time trying to think about, okay, what does the job actually entail? How do you, if you had to break it down and make kind of a checklist of the things that you need to be doing as a chairperson, what does that look like? And this is what I came up with. It's, strategic planning, that's kind of the exciting stuff. You really want to be thinking, on a 5-year or more time frame about the things that the department and the medical center, can and should be doing. There's the basic operations of the department, both clinically and academically. There's the finance and accounting that you have to do. A lot of it is managing personnel. Some of that is staff, people that work in your clinic, people that work in your office, and also faculty. So faculty affairs is a big part of that. Attracting, recruiting, managing, leading, mentoring, I think is exceptionally important. I spoke to one chair when I started this job, and I was asking, hey, how should I do this job? Somebody told me that they thought they were ready to be chair when they had mentored medical students and fellows, and they felt they were ready to be a mentor to faculty. And I thought that was actually a very, very nice way of describing what sort of ideally, at least one facet of what a chair can and should be doing. Something that struck me when I started was just how important communication is. There's sort of this realization, for me, it was sort of in the first week that I started, we didn't, before I came here, have a grand rounds, and I realized, A, that I had to establish a grand rounds, which we decided sort of arbitrarily was Friday morning. But B, that at that grand rounds, I had to sit at the head of the table. I had to be sure that I had introduced everybody, had a question at the end of every lecture, was always, actively communicating updates. Communication is huge. It's a big part of what the chair does. And as somebody who's sort of naturally reticent, I'm not somebody who likes to, I'm less so now somehow, but I really didn't start as somebody who was very talkative. That was a leap that I had to make. And then the last is crisis management. The things will come up, and you need to be on the front line when those things happen, and they come from all directions. And so that's important. If I look at what my experience was with these things, here's how I would characterize it. Really wasn't very much. I had I think done a decent job as a clinician, perhaps as a researcher doing a little bit of work, but in these things I hadn't had any real formal experience, and so it is a leap, and that I think is exceptionally exciting, and for me was that learning curve. Yeah, and not to mention, if you go to a new institution, you don't really even know where the bathroom is, so there's a whole other element that you have to learn how that institution operates, which is its own challenge. I think this is especially complicated in academic medical centers because you're not just leading one effort. If we really think about what academic departments do, there are clinical aspects, there are educational aspects, there are research aspects, there's a community engagement, and then communication. You'll see, so that this is a matrix that I think all of these elements: strategic planning, financial management, operational oversight, etc. Exist, but they exist in each of these venues. And so being able to address that, I had the experience a couple years after becoming chair, I went to get an MBA. And in one of the exercises that we did, we were paired off with other classmates who were not in medicine, at least the person I was with was not in medicine. And the exercise was to describe your job and what you liked about it and what you thought the challenges were. And so I sat with another individual, and I started to describe what the aspects of my job were, and about and this was supposed to be a 5-minute exercise, and 15 minutes into it, as I was going through sort of sequentially, well, here's my clinical role, and here's my educational role, and here's my research role, and here's my he was A, bored to death, but B, said that is a crazy job. And I think it is, and I think that's what keeps it exciting, but also challenging, is that it is multifaceted, and in each of these areas, you have to balance the various elements, and those areas may interact, and I'll touch a little bit on that here. So fundamentally, I think your job as an academic chair is to understand academic medical centers, and there are a lot of different parts of it. For those, has anyone, by a show of hands, which I won't be able to see, has anyone read this paper, Simone's Maxims? I've given this. Yeah, so it's for those who haven't read it, this is really a foundational. It was written probably 20 years ago. It's an exceptionally thoughtful sort of summary of the way academic medical centers operate, and I think it is still very true today, even 20 years later. And to sort of summarize what this is about, I mean, this is what it's written by Joseph Simone, who I think was serially a chair and then a dean at multiple medical centers, and was a very, not in neurosurgery, but a very well-known and established academic leader. And what he points out is that, medical centers are sort of tripartite at the very least. So there's a medical school, there's a hospital, there's often a research institute, and these parts, to varying degrees in different centers, are all competing for attention and for resources. And so your job often is to understand all three parts of that and how they're pulling at each other. Because they have fundamentally different business models. If you look at medical schools, the mission is the education of future physicians. The revenue driver is tuition, perhaps philanthropy. There are strengths. Medical education improves medical care. I think that's wonderful. There are challenges. Education and active practice is always a balance. We all know this, that we're working at the same time to treat patients and also take the time to engage learners and give them autonomy. So these are things that you have to be considering, in your role as a department chair and as a program director, perhaps. Hospitals, has their own, so the mission here is patient care. The revenue driver is facility reimbursement for medical care and procedures, to a lesser degree, professional reimbursement. The strengths, the medical care environment is a great place for education and some kinds of research. There are increasing financial pressures on this, and it's often difficult to maintain the educational and research aspects in light of the pressures on productivity. Research, so mission is basic and clinical discovery, federal funding, institutes, philanthropy, some hospital support in some situations. The strengths, innovation, I think, really contributes to medical care. It's important for education. Funding is limited. There's some of the challenges. Potential conflict between these priorities have to be monitored and watched for compliance. So all of these things are interacting. There has been, this is sort of pointed out in Simone's maxims, that there has been sort of a shift over a century in the way that academic medical schools operate. So there was this sort of Oslerian era that he calls it, which was the medical school was primary in the needs of medical centers. The NIH era, 1945 to 1970, there was a lot of support for research, and that really could almost sufficiently drive departments or research institutes. For the last, really, since all of us have been, I didn't write this right, but until current, from the 1970s on, we've been in this sort of Medicare, Medicaid era where really clinical work is the driver of most things, and other things are in competition to that. If I look at the budgets that I have, the most obvious part of that really is the clinical budget, and everything else is sort of in competition. The extent that I would like to support or bonus or fund research is kind of eked out. If I want to grow a profitable clinical program, that's a whole lot easier to do. And so it's important to recognize that, and that's sort of the field that we're playing on. And again, this is pointed out. This was an article, transformation of academic health centers. This was written by Jeff Balzer at Vanderbilt, and just pointing out that there really is this complex, multifaceted interplay between these various organizations, and being able to do that is a really unique, even for someone with managerial experience. Being able to manage in the context of really multiple business models, I think, is unique. And I find as a chair, often I'm iteratively negotiating with people who are thinking just about the research aspects or thinking just about the hospital system. It's rare to find another partner in this that is sort of having, like you are, to see all the different parts. And so being alert to that I think is exciting in a way that you get to sort of pull this all together. There's a real creative opportunity there, but it is sometimes a challenge. Let me pause there because it's a lot about academic medical centers. Would anyone like to ask a question about that, or if any of the chats have come in that are related to that? I'm happy to answer them now, or I can just keep going.
We have a few questions in the chat. We can either, I think both of you may also have access to the chat. Are you able to see the questions at all?
I am not.
Yeah,
Okay,
I'm not able
okay,
to see them.
okay. So I'm happy to just kind of read a few out if you're fine with interrupting.
That's fine. Or I'm looking at the time. If you want, I can zoom through the red. I didn't realize how long this was going to take me. I can zoom through it and then maybe, what do you think? Are they particular?
Maybe if you want to take a few more minutes and then we'll get to the questions.
Okay, that sounds good. Let me go
Okay.
quick. Um, this is one way that I've sort of thought about leadership. I'm not going to get too much into this because I think I'll run out of time. But this is something called the risk and grid. This talks about roles for leadership. We're sort of all used to, and it basically points out that, in academic medicine, we sort of start here. We're used to working in a relatively small environment. In the operating room, for example, we have a role that is relatively directed. We are going to do this craniotomy, and we are giving, leadership in a pretty directive fashion. So we're doing one thing, and we're telling people kind of exactly how to do it. Leadership exists on a continuum, though, both in terms of how broad the problem is and how much you are stepping away from the actual doing of it. And so, if you move out along the problem definition, you are, you can be micromanaging a broad area of endeavor, which sometimes can be difficult, but sometimes you have to be that engaged, particularly at the beginning of a young department. But ultimately, what you want to move toward is sort of working so that you are working in a broad area, you are growing a broad department that does a lot of different things, but you're not directing every single decision. You're sort of empowering leaders or leading leaders. So I think this idea is important and something that I've tried to create. It gets back to that idea of hiring people so that they tell you what to do, which I think is important. I'll share this just very briefly because this was my own experience. Not things don't always go right, and these are all headlines from my first year as a chair. And I'll let you just be shocked by it for a second here. I mean, it was a kind of a crazy year. So it's important to be alert. Even when you make your best plans, you may find that things don't go the way that you want through forces that are not under your control. I had very little to do with Rick Pitino's outing at the University of Louisville. But that's important. These things are important to be alert to and to be flexible for it. I'll leave you with a couple of sort of principles that I think have helped me as I think about it, right? So one, as it happened when I started my job, I happened to attend a lecture by Malcolm Gladwell when he came to Nashville. And he expressed this idea, which is really drawn from Tom Tyler, of legitimacy. And the principle of legitimacy is that systems should be representative, equitable, and trustworthy. That people have to feel that they have a voice in them, in your leadership. They have to feel that it's fair across the individuals that you're leading, and they have to feel that it's reliable, that it's applied without distinction to each person in the same way. And so I think this is important, and it's helped me think about ways to lead a department. Fairness is important. I like showing this video.
Getting grape and
I don't know if people can hear
so she gives a rock to us.
but these are capuchin monkeys that are given unfair rewards. One is given cucumbers and the other is given grapes. And you'll see that when the one guy is just getting cucumbers and he sees the other one getting something better.
He gives a rock to us now, gets again cucumber.
This is very much how people react. I mean, this is sort of highly conserved. And so I think that's something that I think a lot about is as I'm doing things, when someone asks me for something, I'm always asking myself, can I change my policy to offer that to everybody, or is it one person that I need to make an exception for? I try not to make exceptions. Knowing your place in line is important, right? So these are sort of truisms, you should lead from the front, but you should also eat last. And so I think being mindful of the fact that it's important to be involved. People don't want to follow someone who is just giving directions and not wanting to live by the same standards or help with the actual work. At the same time, I think you want to be careful not to advantage yourself first. When you have opportunities to give advantages, to give bonuses, you want to make sure that you're supporting your faculty and the people around you before you support yourself. And here again is this idea of empowering, something that I think I've seen again and again in the most successful departments is they don't just have one leader. They have someone very capable leading the spine effort and someone capable leading the vascular effort. And each person in their own realm are really driving it in a way that a single chair can't do, that doesn't have the vision to maybe do all those things, couldn't be knowledgeable about all those different areas. And so this is really important. Lincoln on Leadership sort of brings up this idea. Anyone who's read this, it's a great book on leadership, and there's a chapter about Lincoln and Grant and how he sort of discovered Grant and trusted him to sort of run the Civil War from that time on, where he had previously been micromanaging it. And so this idea of having generals, finding those generals, and allowing them to run with things, I think is fundamentally important for successive departments. And then the last thing I'll leave you with, and with just a few minutes left, different departments are different. Not all departments are the same, and you will find them at different stages of growth and success. It's important to recognize that and think about that if you take this position. I think we're all drawn to these departments, right? Sustaining success, and it's great to be a wonderful department that's already been super successful and is famous for the work that it's doing. At the same time, as a chair, there's a real advantage, I think, to being part of a turnaround or even a startup, because you have a lot of creative license there and your ability to make an impact. I think I sort of went through this where I was somewhere between, I don't know, a turnaround and a realignment maybe. And it was exciting to come into a place and be able to sort of shape and attract other people who were like-minded to shape and drive what we've done. So that's something just to consider. So I'll summarize. I think the role of a chairperson is uniquely complex and multifaceted. There's often you come into it with limited experience, but there's a real advantage in sort of being on that learning curve. And I think for functional neurosurgery, this is sort of geared toward ASSFN and functional neurosurgery. I think it's an exciting time to do that. For me, it was really a wonderful transition. I think that functional surgeons in particular are well suited to this because by the nature of what we do, we are collaborative with other departments. We are doing things that are innovative and nuanced and often require us to interact with our hospital system to champion new therapies. And so, being part of all of that, I think it's not a coincidence that we've seen so many great functional chairs, in the last 10 years. It's I think that we're well prepared for that. And so with that, I'll stop talking and be happy to answer any questions.
Yeah, thank you so much. That was some great insight from both of you. I'm just going to read out a kind of question by question and have you both respond. So one thing here is about speaking of the learning curve and some of these different leadership roles that each of you has taken on. A lot of folks out there get additional skill sets through an MBA, like formal degree, proper MBA, or maybe an executive MBA variation. Do you find that going through that is necessary or useful in some way, or better to do earlier on, later on? What do you think would be the timeline for someone interested in pursuing that, and how does it play into seeking future leadership roles?
I can give my perspective. So I looked at the idea. I had a friend when I was at Vanderbilt who did the MBA, and I went and spent a Saturday attending some classes. There was kind of an information session, and I just couldn't figure out what I was going to do with it. It seemed exciting. I kind of liked the idea of being a student again, and I was excited to think about it. So let me stop that. But at that time it really wasn't sensible. I think it's important if you have that education to have a desire to apply it somewhere. When I came back, because several years later I'd been chair for about 3 years, and I decided, hey, I think maybe I want to do this MBA thing. I think then it made more sense because I had already had the experience of being a chair, and I was wanting just to do it better. And for me, it was useful in that sense. What it gave me, I think, was not so much, by the time I had done this a few years, and even before that, even before being a chair, you had to understand basic principles of, finance and management to some extent. But it gave you a language to speak, and that was useful as you're dealing with hospital administrators who are typically MBAs and who have that experience. So I found it useful. I don't know that it was paramount. I think there are, plenty of very successful leaders who have not done an MBA, and I don't. Well, I wouldn't say yes. This must be done. It's an absolute, at least for in my view of it, or at least what I got out of it. I don't know if we can enable other people. I know there are other people who the rest of you, I think, are not able to speak. You're muted. But there are a lot of wonderful people on this call who I would love to hear from, who have MBAs, who are chairs themselves. Be curious to hear others' perspectives.
Wow. I think I've maybe enabled people to so that they can unmute themselves. But another question on this chat is, what tips do you have for a fresh graduate starting a new practice? So things to ask for in contract negotiations and how to build a practice, kind of starting out in the first couple years.
I think in terms of things to ask for, you have to have a pretty clear idea of what you want, I mean, I think we all go through these interviews, or is where do you see yourselves in 5 years, but you actually have to do that, and really kind of think about what resources you are going to need to build the program that you want to build, together with your boss. I mean, I think in terms of how to build the practice, it's going to depend upon what the marketplace is like, and that's going to be different from city to city. In functional, you're completely reliant upon your neurology partners, so be really careful about where when you're looking at jobs, you have to look really closely at who your boss is going to be, but you also have to really look closely as to who your neurologists are going to be that you're going to be working with. Sometimes you can make it work if you have, so like I was in a situation where we kind of lost a lot of our faculty in neurology, and we were really hurting, but I was established enough at that point that I had formed relationships with private practice neurologists, and was able to maintain my practice even though our system had kind of imploded. But that was, I couldn't have done that, just coming out of training. Look at your reps, I have to say that was actually a big motivator, even for me taking, my current job. If you really want to know, like, if you have a good relationship with your industry reps, they'll actually tell you like who the good faculty are, not just in neurosurgery, but in neurology. So that can make a big difference. And they can be really, really useful in sort of telling you what the ground game is like. And you can also use them, in a mutually beneficial way. I mean, they want you to succeed. They want you to do a good job and help the reputation of the program, and of their product, and be doing a lot of more implants so that they can sell batteries.
For those who want to pursue a surgeon scientist route, what recommendations do you have about creating a competitive research package proposal for your job search?
Yeah, I can speak a little bit to maybe what, when you think about this, answers a little bit of the first question, a little bit of the second question. The way I think about a startup package is, I think of 4 elements, right? So the first is time. You need some amount of protected time in order to do the research that you want, or to do the other things that you want, whatever the goal is that you're trying to create. that's a little bit of a misnomer. People talk about protected time, and I was told when I started my job, hey, we have you doing 3 days of OR a week and 1 day of clinic, but the other day is completely yours, so that's 20% protected. That's a pretty full clinical schedule. So what's maybe more important is protected salary, really. What you want is to know that your RVU goal, or whatever the goal is, that you're dealing with, is not the same as others. So if the standard neurosurgeon produces 10,000 RVUs, the standard functional neurosurgeon produces maybe about 7,000 RVUs. Having an RVU goal that's 10,000, no matter how much time you're being protected, is going to be problematic. So that's time or salary that's being protected. Yeah, the second is space. You need lab space, you need clinic space, you maybe need OR time. So those things are important. Equipment, you need some amount of equipment depending on the research you're doing, depending on the clinical thing that you want to start up. You want to make sure to negotiate that at this time, because it's easier to do now, when you're starting that job or negotiating that job, than a couple of years down the road when you may really need it, but there's just not the same leverage that you have. And the fourth, I think, maybe most importantly, is people. Like it really is important in the end, whether it's people working in your lab, postdocs, research assistants, lab managers, whether it's people to help you in your clinical endeavor, physician extenders, etc. It's really the people that make it work. And so taking the time to really negotiate for that, I think, is critically important. That's how I've broken it down, in my own thinking.
How important is committee and society involvement for career advancement? So as a young faculty member, should we be jumping into committees like really early on, or kind of pace yourself and get involved later on? Is there a certain pathway to doing that?
Yeah, I mean, I think you have to be careful about what you volunteer for. So, and I think in terms of things within your hospital, you probably, what Andres Lozano advised me, and I'm sure he advised Joseph as well, was, your first couple of years, don't get on any committees, because you have to have the time to build your research enterprise, build your practice. As you move along, you may want to do that, both internally, but I think probably more so in terms of getting involved with societies. I do think that helps a lot. It's frankly, one of the more enjoyable parts of my job is my relationship with my colleagues across the country, and it sort of keeps things fresh. And as Joseph said, this job is crazy, but having other crazy people with you is really helpful. It also keeps you a lifelong learner. And as someone who's very interested in advocacy, I think one of the big things or big problems with functional neurosurgery is we do procedures that are incredibly underutilized by the American public. And this is not something that's unique to the US, it's a worldwide issue. So, you have to do some degree of advocacy and outreach to bring the patients in. They don't just land in your lap if you hang up a shingle.
True. We'll take one more question, perhaps, and then look at wrapping up this session. How do you go about starting a new job, but having maybe a neurology team there that's kind of been used to doing the same thing, and you're going in as a new neurosurgeon, and changing up the culture a little bit, changing up the way they do things? How do you navigate that kind of situation?
Can you repeat the question? I'm sorry, I was reading some of the other questions that we have online. Can you just say it one more time? I apologize.
Yeah. How do you go about kind of part of the negotiation, but also starting out as a new staff, working with neurologists, different teams of neurologists, and kind of folks that have been used to doing the same thing, for years, and then
Yeah.
changing their mentality?
Oh, that was one. Okay, yes. I think I think it's just a matter of being collaborative, right? Like I think you approach people where they are, you see what it is that they, that they are excited about, what their knowledge is, understand where they are. And, I think you introduce things slowly. When I came here, this was a center that it was a very motivated group of, like our epileptologists were very motivated, very thoughtful, but had not seen a lot of stereo EEG or laser ablation or RNS, which this was in 2016. And so it took a little bit of time to sort of introduce that. And, at one of the, we were having monthly conferences, and at one of them I said, hey, could I just give a small presentation on laser ablation and why I think that's useful and what some of the data is thus far on it. And it really didn't take long for people to come around. I suppose there are times when you have somebody who is resistant or, very fixed on a particular management, but I think, just sort of repeated conversation, repeated introduction, inviting them to be part of, there are any number of, academic and, industry sponsored activities, inviting them to go with you to a course where you're going to learn about it. I think those things can really make a difference.
Yeah, I mean, I think it's definitely a challenge, and you can't bulldoze people. So, I mean, I think, if I think people in general, especially people in clinical neuroscience like us and our neurology colleagues, they're willing to be, intellectually challenged, but you have to do it kind of the right way, where you have to kind of ask them to teach you, to sort of see what they're thinking, and then say, well, maybe I read this paper or I saw this thing or my experience has been a little different. Do you want to try, something else? Or and sometimes you just have to kind of respect what their experience is, as long as it's not crazy, or really problematic. And sometimes, what will happen will be that you may have someone internally that's very resistant to what you want to do or what you think is the right thing to do. But you do that, for another referring doc, and then you can show that the resistant one the good result.
Right. Okay. Any additional comments, or if anyone is able to unmute themselves to ask anything last minute?
I'm happy to stay on if people want to have a conversation. I don't mind staying a little bit later if
This is Julie. I'd just like to say thank you to both Jason and Joseph for great talks, and Neha for moderating this. I think there was so many points that were raised, from all the way from, being a new surgeon to, the things that are involved in hospital leadership. Thank you guys for spending the time. I really appreciate it.
Thank you.
Thanks for having us. This is great. This is very nice.
This was fabulous. Thank you so much. Anyone else have any additional thoughts or questions they'd like to add?
I have a little bit of a silly question, if I may. All three of you, Dr. Politzis, Dr. Schwalb, and Dr. Neimat, have said, this is Robert Bino, by the way. All three of you had mentioned kind of know your value and know what, know what you're bringing to the bottom line of the hospital, et cetera, et cetera. This is a little bit of a nuts and bolts question, but how? How do you determine that? Because what our department here does is they give me an RVU generation month over month, but that doesn't really tell me as a hospital employee what I'm bringing to the bottom line. Every once in a while there's something about contribution margin, et cetera, et cetera, et cetera. But how do we really know what the value is that we are bringing to the hospital?
It is very difficult. is very difficult to get these numbers out of them. They don't really want to give them to you. So it's very hard, but you know, what I would say is, you can at least figure out kind of what, if you can get some of the MGMA data, you know, which was something I did when I was looking at this job, and we're preparing to look at this job, to look at, you know, what kind of functional neurosurgeons are making in similar levels across the country. But to be honest, I think that's still kind of undervaluing our contribution. And the hospitals can, you know, when they figure out contribution margin, there's a lot they can fudge. So you got to be careful as to how kind of costs are allocated. But it's difficult. It's very difficult to get those sorts of numbers. I'm trying, you know, currently to try and get a better idea, even here, you know, because if I'm going to ask for resources or additional resources, you know, I need to know what my marginal revenue is for X additional epilepsy patients a year or something like that. Yeah, so Julie put in the, if you can get the MGMA data or the NERVS data, that's great. You know, the problem is that the chairs have access to the NERVS data, and it's a little harder for us to get it.
Yeah, I think I mean, there are a couple thoughts here, right? So I mean, thinking about the RVUs and the NERVS data, I think that is all very valuable. But really, what drives all of this, if you look at, you know, the finances, the RVU, the professional fee, is maybe 10%, and the other 90% are the DRG payments, the payments to the hospitals for the surgeries that we do. And then even beyond that, if you want to consider, and I think this is a little dangerous, but you can look at, okay, what is the downstream revenue of the CAT scans and the MRIs and the other testing that we do. All of those things are at play, and because it is complex, it you know, it's sometimes difficult to get your hands around. It's, you know, furthermore, I have found, being at a couple different medical centers, they may be variably aware. You know, Vanderbilt was a place where they really did account for all of this, and they were pretty open with it, which was wonderful. It helped me really understand a lot of these things. I came here, and that data, it wasn't that they weren't willing to share it. They often didn't have it. They didn't know it. And so that presents a level of complexity. You know, I think at a very basic level, sort of understanding that the RVUs you produce are only a very small part of the picture, that there's significant downstream revenue, not even downstream, but, you know, there's contribution margin to the surgeries you perform. You know, that alone, I think, is sort of starting to understand what your value is. A rule of thumb that I was provided is that each surgeon has a value of about $3 million to the hospital that they work in. Sorry. So understanding that, I think it's important.
Yeah, but you know, I would say, for example, like I you know, when I was at University of Rochester, which was, you know, now more than 15 years ago, they were actually extremely transparent with you know, similar to Vanderbilt in their contribution margin. Like, you know, I was being told, like, you got to do more, you know, you got to build up. Meanwhile, like my contribution margins were higher than the entire Department of Neurology. And, you know, one of the complex spine guys was doing great on his RVUs and was actually losing money for the hospital because of the cost of the implants, because he was doing scoliosis surgery. So you know, I think it's going to be hard to get real data as to what your RVUs are, but or should be, but you have to know that your value is more than the RVUs, and you also have to know that, like, you know, being asked to produce 10,000 RVUs a year is just not reasonable. You know, so you should have a good idea of, like, what the numbers are for you know, functional neurosurgeons with functional practices. You know, because otherwise you're going to end up in a situation where, like, as you know, let's say you're at some place where you're doing everything and you're trying to build your functional status in your functional practice, you're actually going to hurt yourself financially by doing that, because you're not going to be doing as many lumbar decompressions or things that, you know, are much faster that that you can do well on financially. So you know, that's not a situation you want to be in if you really want a functional practice.
The other thing which I think is really important at this discussion is, particularly as you advance to leadership roles, like just how important it is to be, you know, I think engaged with your hospital as you do this, right? So I mean, we sort of talk about, well, you know, there's always this attitude of know your value, as if the person that you're negotiating with is opposed to you in some sense. And, you know, and there are times when you have to negotiate, but I think it's important. Something that I find is a very critical part of my job as chair is to go to the hospital and say, listen, we have a shared interest in growing these aspects of the surgery we produce. Let's look together at what the contribution margin is of these things that we're doing, and let's figure out which of these is most beneficial financially so that this is sustainable. Let's figure out what we can do to either negotiate better pricing or, you know, look at our implant cost and address that. There, you know, this really, I think at its best is a partnership with your medical center, and that I think is what produces the most successful departments, is departments that have sort of gotten on the same page with their centers and they're working in lockstep.
Hey, Jason and Joseph, this is Dario. First of all, I want to say how great this has been. You know, like, it's been very insightful talks as always. I also want to apologize. I can't turn the camera on. I think I want you to know people aren't trying to be rude. We have a technical issue that we can't turn our cameras on. So hopefully we'll fix that for future. But I think one thing I want to ask both of you that I think is a very interesting question is the energy of activation to making a move, right? And so Jason did that pretty recently, and Joseph, you did that, you know, several years ago to go take your leader. Both of you guys, you know, took leadership positions to make it, but it's also, you know, challenging to uproot your family and move. So like, I would love to hear your just general thoughts about how like how do you balance the benefits of making a move versus the comfort of your home?
Yeah, I mean, having done this more recently, you know, I think it's very, very difficult, you know, to make a move like this to, you know, a different and often to a different state, right? It's a little easier if you're able to stay locally, but then, you know, with non-competes these days, that's even harder to do, and find the right job. So especially if they're, you know, my wife is also an academic surgeon, so that makes it, you know, kind of doubly hard. And it was difficult. You know, I think in retrospect, I mean, I haven't been here that long. I'm very glad I made the move. You know, maybe I should have made it earlier, although I'm kind of happy that we made it after our younger kid, you know, was out of the house and in college. So that made it a little less disruptive for her. But it's hard. It's definitely, you're taking a plunge. I mean, I think you have to sit back. There is an ease in continuing in where you are. I mean, and you realize that all dogs have fleas and all jobs have their negatives. I think the question is, you know, when you're looking at things and you say, you know, we have very limited careers, right? So, you know, we tend to finish in our early 30s or even later, and, you know, and then you have a 30-year career, or maybe 40 at most. And so you got to figure out, you know, for me at my age, you know, I'm sort of figuring out for the next 15 years, you know, what are the things that I want to accomplish? Am I going to be able to accomplish that in my current position? And I didn't feel that I could. So that was really a question of finding the right job for me and my wife. But it's difficult. It's difficult. It's very easy to be kind of comfortable and be in that stagnation mode, like in the graph that Joseph showed, where you kind of putter along and can stagnate before, until you're ready to retire. So I think you have to kind of figure out, you have to really kind of sit down and examine, what is it that I want from my career? Am I going to be, and be honest with yourself, am I realistically going to be able to accomplish that here, or do I need to go someplace else? And then you don't have to be in a rush to get that new job. You can kind of figure out what do you need to do, to get that new job that you want, be able to accomplish your goals.
Thanks, Jason.
Yeah, I think I think this is exceptionally difficult. I do think that, there are a couple of ideas. One is, yeah, being really clear about what your goal is. What is it that you want to achieve with the new job? If it's just, things that there are always going to be minor things that could be better somewhere else. And so if it's just sort of a calculus of, hey, if I add up these things, I think the job is better somewhere else, you may be jumping into something where you just don't know what the downsides are. Things that you take for granted and are pretty good where you are not as good over there, even though the things that you've recognized as problems at your current institution, could be better at the other place. I do think that sort of the clearest decisions come when you're leaping into a new role. When you're, I looked at a couple jobs before I came to this one, and it was really the opportunity to be, in a completely new place, but doing a different job that was most exciting. And once I knew that, it was sort of clear it wasn't this, hey, I'm balancing things. It was exciting. You should be excited about it. Sometimes it's just a visceral thing. If you're looking at something and you don't find yourself kind of excited about what you're going to do there or what it offers you, like I would keep looking, because other things will come along. I wouldn't, you don't want to leap too soon, but you also don't want to, plateau somewhere and then not make a leap because you fear losing the comfort that you had. That's my thought on it. But knowing exactly how, it's a difficult thing to gauge.
Thanks to both of you. Thank you.
All right, this has been fantastic. Any last minute questions? Otherwise, I think we'll go ahead and close out this session.
I would just comment, I've been seeing, somehow I'm now able to see the questions that are coming in the chat here, and Julie is very capably answering most of them, which is great. I would echo her last comment. Like if any individual, who's looking at a particular job change, is wondering about a leadership transition or whatever, would like to talk to us, we are available. I'd be happy to speak to anyone individually about their situation. Julie, thank you for fielding all those questions. It's great.
Yeah, thank you, Julie.
My pleasure.
I will say, just to answer the previous question about organized neurosurgery, I mean, one of the real pleasures of my career has been getting to know this group of people. Many of the people on this webinar, are colleagues that I've met only through ASSFN, and that's clearly been the best part of it. It's just been a tremendous opportunity to get to know other, just wonderful people who are thoughtful, who are engaged in this, and who I consider, mentors today. I called Dario this morning about a case. It's wonderful to sort of have these connections that continue to enrich my career. So I would absolutely recommend it to any young person wanting to look to get involved. You absolutely don't need to be at a well-known institution to get involved. Think about what you would like to do, whether it's in research, education, whatever it is, and reach out to the board, and we'll get you pointed in the right direction.
All right, this has been fantastic. Thank you both so much for sharing all this insight and your perspectives, and I think it's resonated really with everyone on this seminar here. So thank you so much again for your time, and we look forward to seeing everyone again probably for the next session.
Thank you.
Thank you.
Good night.
Have a good night,
Thank you.
everyone.